Welcome everybody to yet another Medartis webinar series, Solidarity Webinar series. It's a great pleasure to introduce Daniel Herren from Switzerland, who's going to talk to us about the distal radio-ulnar joint. As in the previous webinars, please, if you could keep your microphones muted, preferably don't share your video link, because it can slow things down. There will be questions fired at you by Daniel during the talk, and we encourage you to participate in that. But very importantly, also do send questions to Daniel via the chat board, and I'll put those to Daniel at the end. So I'll hand straight over to Daniel. Many thanks for your time tonight, Daniel, and we'll look forward very much to your talk.
Thank you very much, Adam. Thank you very much to Medartis to give the opportunity to have such a charity webinar. And I was very pleased by the question if I could do something. And I tried to put together a potpourri about the very fascinating part of the human wrist, the distal radio-ulnar joint, and I hope it's things in it which everybody can pick out whatever he likes to. And I think to start with and to have a common feeling what we are talking about, we have to take a quick look at the fascinating anatomy of the most important wrist joint, I guess. The elements are clear, the TFCC, which is superficial and deep portions, the foveal insertion, which we got attention to a few years ago and which gets clinically more and more important in terms of detecting pathology over there. The ECU tendon, which is subcheat and quite complex anatomy, providing as a secondary stabilizer of the joint. And last but not least, the ulno-carpal ligaments, which I at least didn't even completely understand what the function is, but I guess they are parts of the stabilizing ulnar-sided wrist system as well. So what's the main function of the distal radio-ulnar joint? When I was in Louisville as a fellow, Louis Schecker keep on saying all the time, listen guys, the distal radio-ulnar joint is a weight-bearing joint. So it's not only the legs, but it's also the forearm, which can be a weight-bearing system. Carl Haggart, the father of Elizabeth Haggart, he also quoted that the ulnar head is the keystone of the distal radio-ulnar joint in the whole forearm, since the wrist is resting on it. And we will see that there are concepts also for distal radius fractures, which just confirmed that idea. We can see this quite impressively when we are looking at patients having had either a distal ulnar head resection or a Sauvé-Kapandji procedure, and they are complaining about some instability. If we let them lift weight and do an X-ray on it, it's quite impressive to see how the ulna is approaching the radius and how unstable the whole system is, since the ulnar head is not longer functioning and is not sitting in the sigmoid notch on that part. We all know about the load characteristics through the wrist, and I think it's still true, at least has been confirmed in several other works. What Wemer et al. Found in the 1980s, that the load is distributed among the radial side of the wrist and the ulnar side of the wrist. And it highly depends on the ulnar variance, how much of the load is transmitted by each of it. So usually we say, and roughly as I say, a rule of thumb, it's about 80% which goes through the radius in an ulnar plus minus variant, in a so-called ulna zero variance, and about 20% of it in the ulnar side. It's quite impressive to see what happens when we are shortening the ulna. So at least in the CAT lab, in the CAP experiment, it really goes down to 5% of loading of the ulnar side, so quite dramatically. This load is changing. It's true the same if we have a problem of a overlength of the ulna for whatever reason, especially after distal radio-ulnar fractures, distal ulnar fractures, where we have a problem either plus or minus, and in the radius fractures where we have a sinking in of the radius, and thus the ulna is longer, and it can be really a problem that a lot of load is now transmitted to the ulnar side, which was probably not foreseen at the beginning. The three-column theory, which got popularized by Rickley and Pietro Regazzoni, which I think is worth to think about and is a nice concept to understand how the wrist is functioning, distinguish as well between the so-called three columns. We have a radial column, an intermediate column, and the ulnar column we're just talking about. If you're looking at the different functions of those columns, we have to realize that the radial column is basically made for stability. It's the osteospatris of the radial side of the wrist. It has the important insertions of the stabilizing capsular ligament, like the radioscaphocapitate ligament or the long radiolunate ligament. We have the intermediate column, which is basically made for load transmission. So the lunate takes a lot of that transmission issues. And the ulnar column, which has low transmissions tasks as well, but also act as a stabilizer. It's the so-called ulnar pivot, where the radius is rotating around and basically the whole hand is rotating around when we are doing pro and supination. So the ulnar column is responsible for a lot of the stability of the wrist, and this can be seen, for example, in such a case where we have a quite complex and dislocated forearm fracture. This is a picture from Daniel Rickley he provided to me. And it was only fixed the radius. The ulnar looks pretty okay at the moment. We already see the radius is quite unstable. There's a huge defect. We can imagine that with that fracture, the ulnar side is unstable as well. And guess what? You know, it looked fine after 6 weeks. It looks terrible after 3 months because the whole thing is falling apart, because the ulnar stability is missing. And in this case, I think the fixation of the ulnar side would be mandatory in order to provide also healing on the radial side of this fracture. So this is just a short introduction about function, just basic anatomy, so that we're all talking about the same thing. So what could be the reasons for a destruction of the distal radial ulnar joints? Of course, well known, the malunited fractures. A lot of distal radius fractures are passing through the sigmoid notch and thus are, even if they are not radiocarpal intra-articular, they are intra-articular in terms of distal radial ulnar joint. We can have an osteoarthritis, quite often seen in the course of a pseudogout or chondrocalcinosis. This is not uncommon, and the older I get, the more I'm convinced that the pseudogout with crystal as a crystal arthropathy is quite often responsible for these osteoarthritic destructions, which we always called idiopathic, which I think is probably not the case, and they might be quite heavily influenced by an inflammatory process. Of course, rheumatoid arthritis is the distal radial ulnar joint, the target joint of the disease. Quite often the disease even starts at the ulnar side of the wrist, which can be seen with small cysts, small irregularities of the ulnar head or the distal part, even the ulnar stylate. There's a lot of space in there where the synovial tissue can expand and attack the cartilage as well as the bone. And last but not least, not very often, but a classical is tumors at the distal ulna, especially the giant cell tumors, which can provide a quite heavy destruction of the distal ulna and thus the distal radial ulnar joint as well. What are the classical solutions for a problem of the distal radial ulnar joint? There are probably a few more, but the really classical ones: ulnar shortening, ulnar head resection, also named after his first description, the Darrach procedure. We have the possibility of having a hemi-resection into position arthroplasties, probably something which got a little bit forgotten the last years, but which was popular at a given time. The Sauvé-Kapandji procedure, and last but not least, implant arthroplasty in different forms. I would like to go through all these different issues and all these different possibilities with case examples, and we'll start with the first one. It's a 55-year-old female suffering from rheumatoid arthritis. She has, thanks to the medication, the biologic, it's MabThera, which she got from her rheumatologist, a stable disease condition. Stable disease condition means that the inflammatory process is pretty well controlled. Quite often these patients have very little pain, and also few inflammation around their hands and the wrist, but still there might be parts which are problematic, which is the case in this female patient. She has a painful forearm rotation. Looking at the X-ray, that's no wonder. It's a complete destruction of the distal radial ulnar joint, which limits also the amount of rotation, which is somewhat compensated by the shoulder. But as we all know, that patients suffering from rheumatoid arthritis, they have problems everywhere almost. This is not a good thing to do. Flexion extension is basically pain-free, but quite heavily restricted. No wonder, I think the only quite semi-functional joint is the mid-carpal joint in this case. You just can see a glimpse of the MCP2 joint, which is painless, but limited range of motion, not an issue of discussion. So the question here, and I would like to address it to you, is what would be the options for you to treat such a distal radial ulnar joint? Is it still a case for ulnar shortening? Might it be just an ulnar head resection? How about the hemi-resection into position? Sauvé-Kapandji? Or can we even talk about the distal radial ulnar joint arthroplasty? I see the answers are coming in, very interesting. You know, the treatment of rheumatoid wrists those days got different than I experienced 20 years ago. So options like arthroplasty, for example, get more popular in those patients, since if they are in a stable disease condition through their medication, you can indicate interventions which you didn't dare to do 20 years ago when patients still had all these phases of very inflammatory processes going on, very heavy inflammation and bone destruction. So looking at the results, interesting. Ulnar head resection is the leader, not by far, but I mean, it's a classic. I will talk about that. Interesting enough, quite a lot of people. So 29% voted for ulnar head resection, 24% of a Sauvé-Kapandji, 17% of a distal radial ulnar joint arthroplasty, and 19% ulnar shortening, which is quite surprising. But the two winners, ulnar head resection and Sauvé-Kapandji, would be my favorite as well. So let's discuss those a bit more in detail. So ulnar head resection, named after Darrach, and Sauvé-Kapandji. The Darrach resection was first described 1911 by Darrach. We have to realize that it wasn't described for different pathologies, but it was basically described for malunion of distal radius fracture, either with an overlength of the ulna because of shortening of the radius or a destruction of the distal radial ulnar joints. It became then popular, especially in elderly patients, less demanding because the surgeons realized post-operative that patients have some limitations. We have seen how unstable a resection of the distal ulna can be, and this has a functional impact. So elderly, less demanding patients are probably the best indications for doing such an intervention. It's very popular in rheumatoid arthritis still. Again, we have to differentiate nowadays because these patients, if they have a stable disease condition, might have other options. There has been descriptions in several papers that if you take away the ulnar head, so you take away the stabilizing part of the wrist, as we have seen at the beginning of the presentation, you tend to destabilize the corpus in certain types of rheumatoid arthritis. As we all know, rheumatoid arthritis is not equal rheumatoid arthritis. We have more stabilizing types of arthritis where the disease tends to fuse the bones, and we have more unstable disease conditions where through the inflammatory process the ligaments are weakened and the bone is disrupted the way that these wrists especially tend to fall apart. On the other hand, the Sauvé-Kapandji procedure, it consists of an ulnar radial fusion with a proximalization of the rotation movement in that regard. So it preserves the ulnar-sided soft tissues, including the ligaments, the TFCC, whatever is remnant, especially in rheumatoid patients. And I think an important point, I'm coming back to that later, it gives a more natural aspect of the wrist compared to an ulnar head resection. If you have seen patients with an ulnar head resection and a Sauvé-Kapandji, the appearance of the wrist just aesthetically is completely different. Who was Kapandji? Who was Sauvé? It's interesting, you heard different stories, but the truth is Medartis, he was born in Macedonia. He's with Greek and Turkish parents, so quite an explosive mixture. He published in 1936 together with his boss Louis Sauvé, which I don't think was a real dedicated hand surgeon, the technique de traitement chirurgical des luxations récidivant isolées de l'extrémité inférieure du cubitus. So pretty French, but the idea was again, you know, to unload or to just take out the distal radial ulnar joint in a way that you proximalize the rotation movement of the forearm. Adalbert Kapandji, which I have met personally, he was the son of Mehmet. He published then a modification with a second screw and a graft in between the ulnar head and the sigmoid notch. He said it's important to keep the distance between the radius and the ulna, so it's instead of just putting the head towards the sigmoid notch, it might be mechanically better to put the bone graft in it and thus make a more sound or more biomechanical situation. It's interesting to look at the literature, and I have to confirm that this is also what we observe in the clinical practice. You know, the difference between the Darrach and the Sauvé-Kapandji are marginal. And if you follow the discussion, it's quite often quoted, the Sauvé-Kapandji is more stable than a Darrach. Well, is this really true? I mean, the instability is in the ulnar stump, and the ulnar stump is as well in the Sauvé-Kapandji as in the Darrach, exactly the same. So even the resection level is a bit lower in the Kapandji because you need to resect a certain amount. It's not much of a difference mechanically, at least in that regard. And as I just quoted, you know, in the literature, indeed, there is no really significant difference in the clinical results in all different regards, with some exceptions. There are descriptions of instability after isolated ulnar head resection in certain type of rheumatoid arthritis. I just mentioned it. Looking closer to those publications, they date back to the 80s. They're not extremely well documented, so the evidence might be questionable. Minami, in a Japanese series in 2005, has seen a difference with a better grip strength in Sauvé-Kapandji compared to Darrach. But also, again, if you look at the paper, it's not completely clear if they really compared apple with apples or if not a mixture of different types of rheumatoid arthritis patients were compared. What certainly is true is that the salvage possibilities are different in the Sauvé-Kapandji compared to the Darrach alone. And as I already said, and I think that's really important, the appearance of the wrist is much more natural in the Sauvé-Kapandji compared to the Darrach. And for me personally, this is almost the only reason to do a Sauvé-Kapandji compared to a Darrach, because the appearance of a hand in rheumatoid patients and this has been seen in several publications, is extremely important. Functionality is compromised in a way or the other, but you know, if you ask the patients what they like about their surgery, these rheumatoid patients, a lot are quoting that they like that their hand looked better after surgery than before. So aesthetics in rheumatoids is extremely important and has to be taken into consideration when you are setting indications. For the Sauvé-Kapandji tips and tricks, you know, the segment doesn't have to be too long, doesn't make sense, it's not more stable, and the screw is just purchased anyhow in the distal third. So it's enough if you have 15 millimeters of ulnar head. Then you have to leave out between 8 to 10 millimeters in order not to have any contact or possibilities that there is a calcification in between, and then the ulnar stump comes. So the ulnar head has to be relatively short. I'm coming back to the screw length afterwards, just going quickly through the surgical technique. I prefer in those wrists, especially in rheumatoids, and the case is a rheumatoid, a longitudinal universal incision, because it's not unlikely that you have to go back to that wrist one day or the other. You need it to have it proximal long enough. You always have to extend it proximally, almost always, because you need more space than you think. You need the ulnar head segment, then you need the segment which you take out, and then the ulnar stumps are coming. You go through the retinaculum. You can do that in different ways. I prefer to go between the 4th and 6th compartment if there is no reason to go more radial, because there is synovitis. So if you have a patient like here with a good controlled inflammatory disease, you can go there. You have to mobilize the tendons, open the capsule centrally, and that's probably a trick which might help and which you can try out. You know, you have to prepare the ulnar head first. And you have to realize that the ulnar head has a much bigger circumference as it's covered by the sigmoid notch. So you have to detect which part of the ulnar head is making contact with the sigmoid notch. That's easiest done if you lift up your hand at the OR table, you put it in a neutral rotational position, and then you can mark the surface in the ulnar head, which has a contact to the sigmoid notch. You put the arm back and then you resect that part and you are completely correct. So it's not necessary to resect the whole thing. Leave in what's possible, just take out what has contact afterwards. And then the rotation is correct because you have a neutral position. Then you can fix it in neutral variants. We leave it there, although in most cases I prefer to have an ulna minus if you put the head a little bit more proximal. So you do the ulna osteotomy, of course, in 2 steps. So the first osteotomy incomplete, so the system of the ulna remains stable, and then you do the second cut complete, and then you can complete the first cut. So that's easier than just complete one cut and everything got unstable and then you have to complete the other one. Then you can set the K-wire, again, easiest in neutral position. If you have the K-wire set preliminary, you can move the ulnar head together with the K-wire and put it in the position you like to. You check it with the fluoroscope, and then you can prepare for screw fixation. A cannulated screw, usually a 3.0 millimeter screw, does the job very well and it's an easy fixation. Closing of the soft tissue is important, I think. The capsule should be a bit tightened in order to get a stabilizing effect. Repair the 6th compartment. The extensor carpi ulnari has a stabilizing function, and if you have a deficient capsule, you can take a part of the retinaculum as a retinaculum flap to reinforce it. You put it in a forearm splint, it's more of comfort, as long as there is not much load on that ulnar head, and I have extremely rarely seen a non-union. No heavy lifting is recommended to the patient. Prosupination is allowed from the beginning. I always do that. I didn't have bad experience with that. And then X-ray control as usual. start strengthening after 2 months. What are the complications? There are few, I have to say. It's quite a forgiving intervention. Non-union is rare, at least it's clinically rare. It's difficult to see if the union took part in a regular X-ray, and we almost never do a CT scan to really confirm the healing, the bony healing. If patient is asymptomatic and fine, you don't have to do anything. So probably there are some non-unions which remain undetected. So the other complication is a calcification. This is not an X-ray of mine, as you can see, because it's so rare. I had one case and I didn't find the original X-ray. It was years ago, and it was a patient who calcificated twice. So I wasn't sure if there is any metabolistic problem behind it. I had to X-ray this patient post-operative in order to prevent a secondary recalcification, and he calcificated the way that it completely got stuck and his forearm rotation was absolutely blocked. So this is really rare. If you have resected the ulnar head segment, take out the periosteum, because that's the part which can calcificate. Stabilization of the ulnar stump, as well in As well in Sauvé-Kapandji as in Darrach procedures, the issue is of unstable ulnar stump. I can tell you, I tried a lot of different things and it's frustrating. Soft tissue stabilization of an unstable distal ulnar stump, very difficult. There are many techniques described, which is always a sign that there is no good one. FCU strip, ECU strip. FCU is technically quite demanding. It's so deep down there, the ulnar nerve is quite around. It would be more logical to use the FCU. It's much easier to use the ECU. That's why a lot of people trying to stabilize it with the ECU, but the ECU pulls the ulnar stump in the wrong direction. It's clear you cannot stabilize a 3D instability, and basically that's it with a 2D reconstruction. And it's interesting, the paper from Kawabata, he's quoting that there is no difference if they stabilized it primarily with the ECU tendon or not. I personally had one patient I never forget. The patient, I did a stabilization of the wrist and a ulnar head resection. Pretty tough guy at the time. I didn't do it as Sauvé-Kapandji. And in order to tighten the ulnar stump, I put in an ECU tendon slip. The patient came to me after 6 weeks and I asked him, how are you doing? I said, since 2 days I'm doing fine because I did a rotation, it came a crack, and since then I feel fine. So I knew exactly it was a tendon strip of the ECU tendon which broke and finally released the distal ulna. So since then I never do such a stabilization again, at least not primarily. An interesting solution, which has been described by Diego Fernandez, is the stabilization, and I did that, the first case together with Diego, with a ulnar head implant. So you can use, as long as the segment is really completely healed on the radius, you can use that as a cup, if you wish so, and if you have a spherical head of the ulnar head prosthesis, you can fabricate again a stable forearm system. This is one of Diego's cases. We see instability documented in the X-ray, then really reaming of the Kapandji segment, I would say, with a reamer to make it round to host a spherical ulnar head, and worked very well. I think I did about 3 patients and they're all doing fine. I didn't have to revise one of those. Let's move on. Malunited forearm fracture. Interesting issue. Now this is a case from Diego as well. Almost blocked forearm after trauma. I show you the X-ray just immediately. Flexion extension limited. That's how the X-ray is looking, terrible. So it's a forearm fracture, completely malunited in all, I would say, basically all planes. And no wonder the patient has these problems. Quite challenging. So again, question for you. What would you do? Very difficult situation. It's not an instability issue, of course. It's a problem. It's a combined problem of the distal radial ulnar joint and the radiocarpal joint. And I wonder what would be your method of choice. We have ulnar shortening alone. Interesting. Ulnar head resection, just chop it out. Hemi-resection and interposition. Sauvé-Kapandji, distal radial ulnar joint arthroplasty, probably together with radius correction. Why not? That makes sense. Interesting. So what we see here is favorite. The favorite is the distal radial ulnar joint arthroplasty with radius correction. Interesting solution. Ulnar shortening is number 2 with 26%. Ulnar head resection alone 14%. Hemi resection interposition 1%. Sauvé-Kapandji 18%. So the favorite is clear. It's the arthroplasty. Let's quickly look at the theoretical possibilities. Ulnar head resection, hemi resection, Sauvé-Kapandji, of course. The hemi resection, just to go through that. What is a hemi resection? Bowers described it in 1985. So he is chopping out part of the corresponding ulnar head and leaves ulnar side the soft tissue intact, and there is an interposition usually of a tendon or a local tissue. Something similar has been described by Watson, or at least popularized by Watson 2 years later, but has been described in the 60s. It's a so-called matched resection arthroplasty. So again, here you have a longer resection, you have a shaping of the distal ulna, and it has been described with or without capsule interposition. I was looking at the Bowers procedure at the time when I was working with Uli Büchler in Bern, and I have to say patients did not too bad, but we had to state at the end that it's a conversion of an unstable, painful distal radial ulnar joint in an unstable, painless distal ulnar joint. So maybe you can take the pain away because there is no more bone impingement, but it's almost impossible to stabilize an unstable joint. So in this difficult case, I think that's not a real option you could think about, but probably then a Darrach would do the job even better as in this problem. But if you only do a Darrach, of course, the radiocarpal joint is unsolved. And as we have seen on the clinical pictures, there's quite a limitation of the flexion extension as well. So, and I agree with the majority of you, congratulations, a radius corrective osteotomy with a ulnar head prosthesis might be an interesting solution. So that's what has been done. So try to re-establish a complete new distal radial ulnar joint. This is the clinical result, quite impressive. So again, it's a case of Diego Fernandez, as we can see, prosupination free. And I think the issue here is there was no instability of the distal radial ulnar joint. It was a malformation, it was a malunion, not malformation, it was a malunion. And the soft tissues were the way that it was possible, and this is extremely important, I'm coming back to that, an ulnar head prosthesis. Nowadays, we will probably do that with computer assistance. So the correction of the radius could be done computer assisted. If it's better or not is still an issue and a matter of discussion going on in the literature so far. They couldn't prove a big difference, just a few parameters were, I mean, at least the radiological correction is much better with the computer, but clinically it doesn't always really show that this makes a big difference. Another case, young female patient, pain at the distal radial ulnar joint comes to your practice. She basically moves freely for prosupination, flexion extension is not an issue. She has a so-called positive compression test. So when you squeeze her ulna against the sigmoid notch, it's painful. That is, oh, it's exactly that. If I'm loading, remember the X-ray at the beginning, if I'm loading my hand, it's painful as well. There is in the X-ray, just showing you that, a significant ulna minus, and it starts to show signs of osteoarthritis. So we have this sclerotic line, we have at least the idea that there's something going on in the sigmoid notch there as well. This is the 3D CT scan. This is a case of Hermann Krimmer's. He published it in the Orthopad 2018. They showed a series of those patients at the IFSH in Berlin, and I think it's a very interesting issue. So, what would you do? Next question. Again, very young, painful prosupination, painful loading. She's really young, so wait as long as possible, an option. Try with a cortisone injection, do some therapy, conservative treatment, whatever, splinting, exercises. Are we already going for a Sauvé-Kapandji and discuss that with the patient? Yes, no. Or how about the ulnar head replacement? So I see it's not a lot of enthusiasm here. I think we can stop. It's kind of equally distributed, but there is a tendency to be conservative. So cortisone injection and therapy is one thing. Usually we start with that as well. Absolutely, I think this makes sense. As long as the progression of the osteoarthritis is difficult to judge, and it's difficult to say how fast it will go. But there's things going on, but at least it gives you some time to try some conservative treatment. What I didn't say is what Hermann Krimmer is doing. So the diagnosis is impingement of the distal radial ulnar joint. This is nicely drawing from Martin Langer. And the plan is corrective osteotomy of the radius. I'm aware of that. I didn't give you that option. I just wanted to tease you with the conservative treatment. And I think it's quite an unusual pathology. And but it's an interesting issue. So this is the plan, to do a corrective osteotomy in order to unload the distal radial ulnar joint, but to preserve it. I mean, the beauty of that is that you preserve the soft tissue and thus the mechanics of the distal radial ulnar joint. These are pictures from a surgery. So you perform this radius corrective osteotomy in terms of a closing wedge, and you are shifting. As we can see here on the X-ray, you are shifting the whole distal block of the radius towards the radial side in order to unload the distal radial ulnar joint, and you fix it solidly with a plate, which allows you immediate mobilization with those plates. And the results are quite impressive. These young patients getting pain-free, a full range of motion for prone supination. So interesting and quite unusual, this case in a young patient. We move on to implant arthroplasty. What are possible indications here? Again, malunited fracture, osteoarthritis, tumors of the distal ulna. Important again is, if you have an unstable distal radial ulnar joint, it's usually not a good indication for a hemi-type of arthroplasty of the distal ulna, nor for just a replacement of the ulnar head or a hemi replacement. This doesn't make a difference. You need adequate soft tissue to stabilize the prosthesis. I had 1 or 2 cases which I was unable to stabilize it, and this is a disaster. Patients never get pain-free, and whatever you do in the rehabilitation, it's almost impossible if you don't have the stability on the OR table to get it later. Just distal radial ulnar joint prosthesis, some surgical hints and tricks. Extremely important, as I just mentioned, is the ulnar-sided stabilization. It's called the ulnar sling procedure by the authors. So the retinaculum is used as a sling in order to hold the ulnar head correctly into the place. What is the ideal position of a distal radial ulnar joint prosthesis? That is important as well. So ideally, and this is really an issue, don't create an impingement with the corpus. So go for 2 millimeter ulna minus. Most implants, the resection guides they offer, they already incorporate that in the resection level. It has to be well canted in the sigmoid notch. Again, the resection level, and that's quite a good mark for different implants. The pronator quadratus is a good reference. And again, soft tissue stabilization, soft tissue stabilization, soft tissue stabilization. Extremely important. Rehabilitation, as long as you have a stable system and good soft tissue, you don't need any fancy thing. A wrist splint is enough. And Diego said nicely, if you need an above elbow splint, it was a wrong indication. Again, it's difficult to stabilize an unstable prosthesis with a rehabilitation protocol. And I completely agree with that. So you have to be aware of if you set the indication. If you have an instability, if you have situations with different interventions before and especially a missing ulnar head, an instability altogether, a painful situation, then a constrained implant arthroplasty might be really a good solution because it recreates a stable forearm again. It has been designed for revision. I'm aware of that it's used from time to time for primary interventions as well. I think it depends on the pathology. It's also good if you already had a Darrach and the Darrach and the Darrach, you know, the several level resection of the distal ulna. So it's still possible to create a stable system with that implant. There are more and more reports also with good long-term or at least mid-term results. When it first came on the market, we were quite hesitating to use it because we thought it so much constraint into that it might be difficult that we get good long-term results. I think ulnar head prostheses are a bit underestimated and probably a bit underused. If they are good indications, they are good results also in the long term. Unfortunately, less and less industrial partners offer ulnar head. I just got an email today, interestingly enough, that one of these hemi prostheses, pyrocarbon type of prosthesis, has been drawn from the market. This is all a problem of the new medical device regulation, that companies are really thinking about what implants do they recertificate for the market. And that's why we see in hand surgery, and we will see that even more in the future, that implants are disappearing from the markets, and this might be a pity. So I would almost say last but not least, ulnar shortening. Ulnar shortening is an interesting intervention. Ulnar impingement is an issue. It can be a problem post-traumatic. It can be so-called idiopathic. I don't think we completely understand what's going on. We all know that ulnar impingement is even possible in an ulna minus variant. We quite often see it in younger patients, often females, lax patients, so maybe it has something to do with some sort of instability. We know that the distal radial ulnar joint has this rotating movement, and the length of the forearm is changing with this screw movement in prosupination, so maybe it's a dynamic issue. The TFCC has different configurations in different issues. So if you see that patient is coming to you, he has a painful ulnar side on the wrist. If you do the classic ulnar impingement tests, whatever you are used to in a clinical practice, and you have then at the end, you don't see a lot in the regular X-ray, but you do an MRI and you see that, and it corresponds what you find clinically. What would you do then? Wait and see. A lot of patients are pleased if you tell them, listen, we don't have to hurry and see, maybe it goes away, whatever. Try to modify a little bit your activities. Infiltration. Certainly an issue. I know there are cultures which a lot of cortisone is used by hand surgeons. There are cultures which is basically unknown. We in Switzerland tend to do quite a lot of infiltrations with local acting cortisone. Arthroscopic debridement without wafer, you know, there are variations of that. Ulnar shortening osteotomy, or maybe even all of the above in that sequence. I see, of course, I already announced it. Thank you for answering. Ulnar shortening osteotomy is the favorite, it's 51%. Number 2 is 35% is all of the above in that sequence. I'm coming back to you. Arthroscopic debridement has 10%, and the wait and see and the infiltration is not extremely popular. We tend to do what is mentioned under E, all the above. So quite often, it depends whom has already seen the patient, how many hand surgeons, whatever. But usually we tend to wait, modification of activities. We very often or almost always infiltrate with a local acting steroid. Arthroscopic debridement is a possibility, something just, you know, to see the cartilage, to do a local debridement. But last but not least, the ulnar shortening osteotomy, and I agree with the majority of you, is here an elegant solution. Ulnar shortening, quite forgiving as a procedure in terms of results, not extremely forgiving in terms of pearls and pitfalls. If you look at the literature, you are shocked because there is a relatively high non-union rate. Now the shock gets then relative if you start to look at the surgical methodology, and then you realize that quite often inadequate bone fixation has been used. I have seen cases with screws only. Not rarely you see very short plates. This is a problem because the forces in the prosupination on the ulna are dramatic, and torsion forces are impressive. There might be an imprecise osteotomy, not enough cooling, whatever, you know, all these biological issues going together with the osteotomy technique. There might be insufficient bone contact. This is a question of technique at the end as well. So what's the goal of the shortening? It cannot be generalized, but usually whatever you have as a variance in the ulna, you head for a slight ulna minus. We all know from extreme situations of malunion of the distal radius fractures that the correction of more than 1 centimeter is difficult. There's a lot of tension of the soft tissue on it, and it needs quite a lot of forces to put after the osteotomy to the two bone ends together. The classical ulna osteotomy in ulno-carpal impingement is pretty straightforward since the introduction of ulnar shortening systems, which are very elegant. There are different systems on the market. The principle is basically very similar to all of them. You have a pre-mounted plate which allows you to define the correct place of the osteotomy, and with different devices, after cutting and taking out the bone chip, you can slide the osteotomy together and fix it. There's always a discussion about volar versus lateral approach. What is better? I have to say we try both, and to be honest, and this is the last point here, tell the patient that the hardware removal is extremely likely, especially in young ladies, even if you go volarly. So it's my experience that once in a while you can leave it, but then you can leave it even if it's lateral. There has been an issue about midshaft versus distal osteotomy. With these osteotomy systems, it tends to be more a midshaft osteotomy because the plates are pretty long, which is good for fixation, and they fit the best at the flat surface of the ulna, which is more proximal, which then places your osteotomy more on the proximal than on the distal side. There are several schools about oblique and horizontal bone cuts. We definitely prefer oblique bone cuts. There's a longer surface. The gliding of the two cuts together is nice. So I think that's a matter of technique, but it allows you to put in an angle. It allows you to put a screw through the osteotomy, and I think these interfragmentary screws add a lot of rotational stability to the osteotomy. Angle stable screws as well, a mixture of cortical and angle stable screws make often sense, and it has been shown in the lab on different occasions that the mixture of those two fixation systems have the best stability which can be provided. So much about ulnar shortening. Just to sum it up and wrap it up, for me, the distal radial ulnar joint is the most fascinating joint in the hand, I think. It's very complex, with starting with the anatomy from the bone side, and especially soft tissue, the interaction with the radiocarpal joint, the interaction with the radius, and we have seen different pathologies which can be a problem of both of it or one of it. So I think it's absolutely interesting to treat, but it's challenging. We have to be aware of, and this was one of the goals, to show you that the variety of intervention is quite impressive, and we probably tend to forget about the one or the other. We have our standard procedures, but if you open up a little bit your mind and think about other solutions, you might individually find even better solutions for an individual problem. Again, as Louis Schecker said, hi Louis, it's a weight-bearing joint, and we have to respect that function. So taking out the ulnar head might be a good solution for a specific patient group, but as long as we can provide a stable forearm system, it's for the functioning of a hand quite important. Revisions is always an issue. That's not only true for the distal radial ulnar joint, so we always have to think ahead if you put indications. So don't burn bridges in a way or the other. And I can tell you, and I'm sure you all know, that a one bone forearm is a disaster. So we probably have almost all seen cases with multiple interventions at the distal radial ulnar joint or the forearm ending up with a one bone forearm, and I think this could be avoided. I thank you very much. I hope you could take one or the other thing a bit out and have some sort of stimulation when you see next time a patient with a problem of the distal radial ulnar joint. If it's the case, I would be very pleased. Thank again to Medartis and the whole crew who was organizing it. Thank you, Adam, for taking over now. Questions, discussions, whatever is asked. Thanks a lot.
Brilliant, Daniel. Thank you very much indeed. Really a very comprehensive talk. You've covered a huge amount of ground in great detail, so thank you very much for that. Please do fire in your questions to Daniel on the chat board. If I can start things off, Daniel. One area that we maybe haven't covered is the unstable DRUJ in the absence of an arthritic joint. What are your thoughts about that, and how to address that challenge?
Yeah, I left this out because I think it's a talk of its own. You know, what I learned, especially also from Ladislav Nacz, who did also publications on that, is the first thing, if I see an unstable distal radial ulnar joint, you have to find out the source of it, of course, we say. But we see regularly patients which had a whatever type of stabilization of the distal radial ulnar joint, not realizing that at the end of the day, it's a malunion of either the radius, most of the time, or the radius and the ulna, which goes back maybe even to childhood. So you have to sort out, is it a soft tissue instability? Then it's more or less quite often a traumatic situation. Or is it a instability due to the bone architecture, which is not correct? Now the TFCC and MRI, we could talk hours about that. We all know that if both of us would going for an MRI, we would have a disastrous picture on our TFCC with no clinical value. So it's quite often difficult to say if you have a soft tissue TFCC problem, if it really matters or not. So I think what we tend to do in those patients, which we really consider a stabilizing procedure, to do a comparative CT scan in order to see if the other side has not had any trauma or any problem, in order to see if it's not a malunited forearm fracture situation, which causes at the end of the day this instability.
So is that a CT of the whole forearm that you request for that time? Yeah,
there's a certain protocol for it. You know, there are certain companies. We have our radiologists. We are working together with Just Mark, and they have a certain protocol. They already deliver the matched scans on it, and they can tell us in degrees how much of difference there is, and you have to find out if this really probably is the problem of that issue. Other than that, you know, if you have a clear traumatic instability, TFCC lesions, TFCC refixation, very mixed results. Quite often the tissue, you know, patients coming late, they had several injections, they had therapies, so the tissue is not very healthy and not very good anymore for just to be reinserted. But once in a while you are tempted to put in a anchor and put it back, especially the foveal insertions, but most of the time this is insufficient. So if the bony architecture again is good, a TFCC reconstruction quite often makes more sense.
And what are your thoughts regarding the importance of the distal oblique band of the interosseous membrane to stability? You mentioned the TFCC as a soft tissue stabilizer. What are your thoughts on that?
Difficult. I think that's a very, very difficult question. There has been descriptions. You know, what we know, to put it the other way around, is that the interosseous membrane is quite a lot of sources of limited prosupination in post-traumatic cases. We only see that. If it scars down, there has been rupture, that's a problem. Instability and how much the interosseous membrane contributes to the instability, difficult to say. I mean, probably you can give us a hint how you manage that, but no, MRI is not very conclusive. If you distally things are quite well, this might be a source, and reconstruction of the interosseous membrane is described. To be honest, I never did one.
No. Okay. So we have a question from Suri Ankarath, who's asked about a middle-aged working gentleman with symptomatic primary DRUJ arthritis, but an ulnar neutral wrist. I suppose maybe this is maybe a manual worker. What's your thoughts about the management of that patient?
I think I sense the background of that question. Should you put that patient a arthroplasty in or not? And this is an ongoing discussion. I think what we know, and from the published series, at the beginning we were extremely cautious with arthroplasty in manual workers, but meanwhile experience, but as well as publications show that it's quite suitable for manual workers, and the long-term results are not worse than in patients which have a more leisure type of work or more white collar type of work. So I think the option of a arthroplasty is here quite tempting. You know, if in osteoarthritis, almost always the distal radial ulnar joint is well centered. The bony situation is the way that the older hair prosthesis can be well seated. The sigmoid notch has usually a very rounded, not rough surface, which if you go for a hemiarthroplasty, which would make sense, is a good cup for the ulnar head. So an ulnar head prosthesis would be definitely an option in these patients. The alternative for me personally would be a Sauvé-Kapandji.
And with regard to your choice of ulnar head prosthesis, would you prefer a prosthesis that replaces the whole of the distal ulnar, or one that just resurfaces the articular surface?
This depends a little bit on the length, and as you said, it's an ulnar neutral variant. I would go for a partial ulnar head replacement. Yeah. I think it's a nice solution. It preserves the soft tissue on the ulnar side. It is biomechanically more sound. So this would be the ideal solution personally for me. If you have a problem, you can convert it in a hemi-resection into position type. So you have revision options if you do that. Mm.
So Jindrik Vorjak has asked about the extreme ulnar plus variants, 20-25 millimeters, because of distal radius malunion. Do you do extreme ulnar shortenings in that situation?
It depends. You know, I always say, my fellow, if you don't know the answer, just say first, it depends. It always depends. No, this is a classical situation. So if you analyze it, and I know this is basics, but we tend to forget sometimes, the problem is the radius. And you are addressing the good bone. And so in these extreme situations, you could really think about a double intervention, as long as there is a situation where you can reconstruct some sort of the sigmoid notch. It's probably better to do a combined radius lengthening, corrective osteotomy, with a shortening of the ulna.
Yeah.
So, because 25 millimeters is a lot, and a lengthen of a radius of 2.5 centimeters is virtually, I don't say it's impossible, but it's a lot. So maybe if the ulnar just goes a bit towards the radius in the leveling, this might be an interesting solution. So I would tend to do something on the radius as well.
And Nitin Savant has asked about when you're performing a Sauvé-Kapandji, and I suppose the same thing would apply to a Darrach's. Do you bevel the cut of the proximal cut of your ulna, rather than just doing a straight transverse cut to try and minimize the impingement on the or point loading on the radius?
To be honest, yes, I do, but to be honest, I do it because it looks nicer on the X-ray. If it's unstable, it will impinge anyhow. Even if you have an oblique cut, an oblique surface there, yeah, it looks just better, to be honest.
Yeah.
So I don't think you can avoid impingement with that.
I think often, I mean, the basic problem is not an unstable ulnar, it's an unstable radius, isn't it? And everything we're doing is to try and is often tackling the ulnar, but the ulnar is innocent, and it's the radius that's at fault, isn't it?
As I just said before, absolutely, yeah.
Yeah. So we have a question about distal radius malunions. Whether you would prefer an ulnar shortening or a corrective osteotomy in general. I suppose it's going to be horses for courses, isn't it? But in general terms, given that the ulnar is innocent, would you rather do something to the radius?
Again, it's quite a philosophical question, and it depends a bit on the analysis of the CT scan and how much correctability would be. You have seen in several cases, even if the sigmoid notch is not completely even, has a little bit of step off, the ulnar shortening might work pretty well. So I would really consider a corrective osteotomy if you really have a situation of the sigmoid notch which is devastating and which unlikely can host the ulnar head in a way or the other. And other than that, I think ulnar shortening has a good potential.
Okay, so we'll take one last question, Daniel, which is from Zaid Hamoudi. So in case of distal radius and distal ulnar malunion, what's your preferred surgical approach? So how do you do two separate incisions? If you're doing an ulnar head replacement, what approach would you use for that?
I think usually, but almost always you do a corrective osteotomy of the radius from the volar side. So you have to do two separate incisions to go from dorsal for whatever you're doing to the ulna for that. So I don't think you can address everything in one step, just in probably some special situations, but volar side corrections, that's the way to go as a standard procedure for the radius, and the rest is done according to whatever you have planned for the ulna.
Fantastic. Daniel, absolutely fantastic. Really great of you to share your expertise, and I think you've covered a very complex topic very clearly and in great detail. So thank you very much. For next week, everybody, we'll welcome you again at 5 p.m. For olecranon plating, dorsal versus parallel plating with Graham King, Lars Muller, and Denise Eigendal. So we'll look forward to seeing you then. Many thanks once again to Medartis and particularly to you, Daniel.
Thank you very much.
Daniel.
Have a nice evening.